Bismillahirrahmanirrahim. Assalamu alaikum everyone and welcome back to OBG with Sadia Idrees. I am Dr. Sadina's consultant obstetrician and gynecologist. In the previous part of our induction of labor lecture, we discussed the guideline in detail about when to induce and how to assess the cervix, which method to select, and how to monitor the mother and baby. But knowing a guideline and applying a guideline in an exam are two completely different things. So today, and I'm not going to teach you the guideline again. Today, I'm going to test you. We have 20 high yield single band answer questions on the induction of labor. And these questions are designed around the areas where candidates commonly get confused, like bishop score less than or equals to 6, about amniotomy, about mechanical methods, Dinoprostone versus misoprostol, previous cesarean birth, monitoring, hyperstimulation, failed induction. And here is a rule for today. For every question, pause the video before I reveal the answer. Read the stem, identify the clue, choose one option, and more importantly, ask yourself, why is my answer correct? And why are the other answers wrong? Because that is exactly how you become good at single best question answer. So keep a pen and paper with you. Give yourself 1 mark for every correct answer. And at the end, we'll see, can you score 20 by 20? So ready? Let's begin. So, question number 1, a low-risk primary gravida attends a 39 plus 2 weeks. She asks whether anything can be done to increase the chance of spontaneous labor before formal induction. What is the most appropriate option? Option A, amniotomy. Option B, IV oxytocin. Option C, membrane sweep. Option D, vaginal misoprostol, and option E, balloon catheter. Now, this is a beautiful question because the examiner is testing you whether you can differentiate membrane sweeping from formal induction of labor. The correct answer is C. A membrane sweep is not the same thing as amniotomy. During a vaginal examination, if the cervix admits a finger, the examining finger is passed to the cervix and rotated to separate the membranes from the lower uterine segment. Why do we do this? Because this local mechanical separation promotes endogenous prostaglandin release and can increase the likelihood that labor will start spontaneously, thereby potentially reducing the need for formal induction. And notice the gestation in the question, 39 plus 2 weeks. That is your clue. According to NICE, at antenatal visits after 39 weeks, women should be offered a discussion about whether they would like a vaginal examination for membrane sweeping. Now let's eliminate the distractors. Would I perform an amniotomy in this low-risk woman just because she wants spontaneous labor? No. Amniotomy is an actual induction intervention and is used in the appropriate induction pathway, particularly when the cervix is favorable. So IV oxytocin, again, no, because we are not formally inducing her at the point. Misoprostol and balloon catheter, they are cervical ripening and induction methods. They are not what this question is asked for. So remember this very simple exam line, near term before formal induction, think membrane sweep and counsel her that membrane sweeping may cause discomfort, it may cause pain, and it may cause some vaginal bleeding. So one more little trap, if labor does not start after the first sweep, additional membrane sweeping may be discussed. So the answer is option C, membrane sweep. Okay. Now, question number 2. A woman is admitted for induction of labor. Vaginal examination shows a Bishop score of 5. What is the most appropriate initial approach? Pause and answer. Option A, amniotomy alone. Option B, IV oxytocin alone. Option C, cervical ripening. Option D, cesarean birth. And option E, expectant management. So the correct answer is option C, cervical ripening. Why? Because NICE guideline says it divides the initial method of induction according to a very important threshold. Bishop score less than 6 and Bishop score more than 6. A Bishop score of 5 means the cervix is not yet favorable for amniotomy based induction. So our first job is to ripen the cervix. Depending on the woman's circumstances, preferences, and contraindication, this may involve a pharmacological method or a mechanical method. So now look at the distractors. Amniotomy alone, no, not the standard initial choice with a Bishop score of 5. IV oxytocin, again, no. Oxytocin is not being used simply to bypass an unfavorable cervix. Caesarean birth, of course, not merely because the Bishop score is 5. An unfavorable cervix is not itself an indication for cesarean section. Expectant management only, this stem tells you she has already been admitted for induction. So unless there is a reason to reconsider the indication, that doesn't answer the question. So your exam formula is this. Bishop score less than 6, cervical ripening pathway. And Bishop score more than 6, amniotomy plus IV oxytocin. You're going to use this rule repeatedly today, so lock it down. Okay. So now let's make the same concept one step harder. Now, a woman undergoing induction of labor has a Bishop score of 4 and no contraindication to pharmacological induction. Which is an appropriate method? IV oxytocin alone, vaginal dinoprostone, immediate amniotomy, mifepristone alone, or IV dinoprostone? So, pause. Correct answer B, vaginal dinoprostone. Dinoprostone is prostaglandin E2 and it is one of the pharmacological options used when the Bishop score is 6 or less. NICE includes vaginal dinoprostone as a tablet form, in gel form, or controlled released vaginal delivery system depending on the preparation clinical circumstances. And this is where I want you to stop memorizing drug names randomly. First ask, is the cervix favorable or unfavorable? If the Bishop score is less than or equals to 6, it needs ripening. Then ask, can I use with pharmacological ripening? If yes, the dinoprostone is one appropriate option. Now eliminate other distractors. IV oxytocin alone, no. Immediate amniotomy, not your first pathway with Bishop 4. Then mifepristone alone, not the routine cervical ripening option for a life-term pregnancy in this context. IV dinoprostone, no. The nice induction options we are discussing involve vaginal dinoprostone, not routine IV dinoprostone. So if an exam gives you Bishop score 4 plus pharmacological method appropriate, think vaginal dinoprostone or low dose misoprostol depending on the options given. And that brings us perfectly to the next question. Question number 4. A woman with an unfavorable cervix is being counseled regarding pharmacological cervical ripening. Which regimen is included as an option in the NICE guideline? Option A, oral misoprostol 10 micrograms, or oral misoprostol 25 micrograms, oral misoprostol 50 microgram, vaginal misoprostol 100 microgram, IV misoprostol 25 microgram. Now be careful, the examiner has given you multiple doses and routes. Pause. Correct answer, oral misoprostol 25 microgram. And this is a very useful exam fact. For women with a Bishop score of 6 or less, NICE induces low dose misoprostol 25 microgram tablets as one of the pharmacological options. The word I want you to remember is low dose. Low dose. Why are we cautious with prostaglandins? Because pharmacological induction can produce uterine hyperstimulation, which can then affect the fetal well-being. And here is another important conceptual point. Misoprostol and dinoprostone are not drugs that you give and then forget about. Once contraction begin, you must assess uterine activity and fetal well-being. We'll actually test that in another question. So for this question, 10 micrograms, not the nice regimen given here. 50 micrograms, too high for the recommended low dose oral option in this context. 100 micrograms vaginally, definitely not. IV misoprostol, no. 25 micrograms orally is the answer. Tiny dose, very high yield fat. Okay. So now this one needs more clinical thinking. A woman, a woman with a previous cesarean birth requires induction. Her Bishop score is 4. There's concern regarding pharmacological hyperstimulation. With which method should particularly be considered? Option A, IV oxytocin alone. Option B, oral dinoprostone. Option C, balloon catheter. Option D, vaginal prostaglandin F2 FA. And option E, misoprostol. Pause. Correct answer is C, balloon catheter. But I want to teach this carefully because previous cesarean induction should never become a one-line shortcut of scar equals balloon. First, induction after a previous cesarean requires proper counseling. The woman should understand that induction can affect the likelihood of successful VBAC and is associated with an increased risk of uterine rupture compared with spontaneous labor. You must also consider the method used. Prostaglandins can cause uterine hyperstimulation, and some preparations have restrictions or contraindications in women with a uterine scar according to their product information. So, mechanical methods such as balloon catheter do not produce pharmacological or uterine stimulation in the same way. That makes a mechanical method particularly relevant when pharmacological methods are unsuitable or there's concern about hyperstimulation. And look at this stem. It practically hands you the clue. Previous cesarean plus bishop 4 plus concern about pharmacological hyperstimulation. The examiner is steering you towards a mechanical cervical ripening method. But please don't walk out of this lecture saying previous cesarean always mean balloon. No, the actual clinical decision is individualized, involving the indication for induction, cervical status, previous uterine surgery, maternal preference, and local protocol. That distinction separates memorization from understanding. Okay, now I'm going to flip the bishop score. A multiparous woman requires induction. Her bishop score is 8. What should be offered? A, vaginal dinoprostone. B, oral misoprostol. C, balloon catheter. D, amniotomy plus IV oxytocin. And E, membrane sweep only. Don't look at the answer yet. What was the magic threshold? The correct answer is D, amniotomy plus IV oxytocin. This is the other half of the NICE algorithm. If the bishop score is more than 6, NICE recommends offering amniotomy and an intravenous oxytocin. Why? Because the cervix is already favorable. You do not need to spend time ripening a cervix that is ready for labor. So dinoprostone, no need. Oral misoprostol, again, cervical ripening is not required. Balloon catheter, same problem. It is a ripening method. And membrane sweep only, we have moved beyond trying to encourage spontaneous labor. This woman actually requires induction. So here is a line I want you to be able to say almost automatically 6 or less ripen. More than 6 ARM placenta. And one worth remembering that NICE says the woman may choose to have amniotomy and delay starting oxytocin, but counsel that this may mean labor takes longer and may increase the risk of neonatal infection. That little line is exactly the sort of detail that can become a future question in your exam. Okay, question 7 looks ridiculously easy, which means this is the exact sort of question people get wrong by rushing. A woman is admitted for induction. The head feels high and the presentation is uncertain. What is the most appropriate next step? A, perform ARM. B, start Synto, oxytocin. C, perform ultrasound to confirm presentation. D, insert dinoprostone immediately. And E, start misoprostol. See, a woman is admitted for induction and her head is high. What is the most appropriate next step? Perform ultrasound to confirm fetal presentation. And the principle here is very important. Before you induce labor, make sure you know what you are inducing. Before induction begins, assess the fetal presentation position, assess the level and stability of the fetal head. If presentation is uncertain clinically, ultrasound assessment is appropriate. Why is this especially important with a high head? Because performing an amniotomy when the presenting part is high or unstable can increase the risk of cord prolapse. So ARM is absolutely not the first thing you do here. And giving prostaglandin starting Synto before clarifying presentation also misses the fundamental safety issue. So before induction, think systematically. confirm the indication, exclude the contraindication, assess the presentation, assess the head level and stability, assess the cervix and Bishop score, and confirm the fetal well-being. Then choose your induction method. Safety before stimulation. That is the pearl from this question. Okay. So now question it connects beautifully with question 4. Following Dinoprostone administration, now uterine contraction begins. What should now be assessed? A. Maternal pulse only. B. Bishop score only. C. Fetal well-being and uterine contraction with CTG assessment. D. Ultrasound fetal weight. And E. Maternal temperature only. Correct answer is assess the fetal well-being and uterine contractions with CTG assessment. This is an extremely important safety point. After dinoprostone or misoprostol, when contractions missing, assess the fetal well-being and uterine activity. Why both? Because prostaglandins can cause excessive uterine activity or hyperstimulation. And if contractions become too frequent, or prolonged, uteroplacental perfusion can be compromised, which may produce fetal heart rate abnormalities. So don't simply ask, is she contracting? You ask two questions. What is the uterus doing and how is the baby responding? If the fetal heart rate is abnormal or contractions are excessive, do not give further doses of the induction medicine. And if the hyperstimulation occurs, further doses should be withheld. Removable vaginal products should be removed if possible, and tocolysis may need to be considered. So that is why option C is so much more complete than checking maternal pulse or temperature. Maternal observations are, of course, part of the overall care, but they do not answer the specific safety point being tested. So remember, prostaglandins given, contractions start, assess uterine activity and fetal well-being. And that closes our first 8 questions very nicely. Because look at what we have already built. We started before formal induction with membrane swimming. Then we use the Bishop score to choose a pathway. We learn lesson 6, cervical ripening, pharmacological options, which include vaginal dinoprostone and low-dose misoprostol. Where pharmacological methods are unsuitable or hyperstimulation is a concern, think about mechanical method. More than 6 Bishop, amniotomy plus IV oxytocin. Before starting induction, confirm the presentation and head stability. And once pharmacological induction start, reproducing contraction, monitor uterine activity and fetal well-being. So now we have learned just how to start induction safely. But now comes an equally important question. After dinoprostone, contraction begin. CTG is confirmed normal and the woman is otherwise low risk. What may be the appropriate next step? A. Mandatory continuous CTG until delivery. B. Intermittent auscultation if no other indication for continuous CTG. C. Immediate cesarean birth. D. Stop the induction. And E. Give tocolysis. C. I want you to tell me the correct answer is intermittent auscultation, provided there is no other indication for continuous CTG. And this question tests a very important common misconception. Some candidates think induced labor equals continuous CTG forever, not necessarily. After dinoprostone or misoprostol, once contraction begins, you assess the fetal well-being and uterine contraction. If the CTG is normal and there are no other risk factors requiring continuous CTG, then continuous electronic fetal monitoring does not automatically have to continue simply because induction was started with the prostaglandin. You can use intermittent auscultation according to the appropriate intrapartum monitoring pathway. But notice the wording, if no other indication for continuous CTG, that phrase is doing a lot of work. If this woman develops an abnormal fetal heart rate, excessive contraction, meconium, maternal complication, no another recognized indication for continuous pregnancy, then the plan change. So never learn after prostaglandin stops CTG. Learn that when you give prostaglandin, contractions start as a CTG in uterine activity, and reassuring and otherwise low risk intermittent auscultation may be appropriate. And now suddenly our patient is no longer reassuring. After prostaglandin induction, a woman develops excessive uterine contraction associated with an abnormal fetal heart rate. What is the most appropriate immediate management? Give another prostaglandin dose, start oxytocin, stop further induction methods, assess fetus and remove vaginal preparation if possible, perform membrane sweep and observe for 2 hours. This is uterine hyperstimulation. Now, and we have moved from a routine induction into a potential fetal compromise situation. So the first principle is stop adding fuel to the fire. Do not give another prostaglandin. Do not start Synto. Stop further medication. So the option is C. Assess the fetal well-being with CTG and reassess the woman clinically. If a removable vaginal prostacyclin preparation is in place, remove it if possible. And if hyperstimulation persists, consider tocolysis. Now, why are we so concerned? Because the fetus receives placental blood flow mainly during the relaxation period between the contraction. If contraction becomes excessively frequent or prolonged, there's less recovery time between them. That can compromise uteroplacental perfusion and lead to fetal heartbeat abnormalities. Am I clear? So the exam sequences stop, reassess, remove as if possible, manage the excessive uterine activity, and consider the tocolysis. And one more important pearl, some prostaglandin preparations are easier to remove than others. So control release vaginal insert may be removable, but once you have given a vaginal gel or an oral drug, you obviously cannot simply retrieve that dose. That difference matters clinically. Okay. Now I warned you that some numbers were coming. Question 11, which contraction patterns meets the nice definition used for uterine tachysystole? Option A, 3 contractions per term per 10 minutes for 10 minutes, more than 4 contractions per 10 minutes for 10 minutes, or more than 5 contractions for 10 minutes for at least 20 minutes, and more than 6 contractions for 20 minutes, or any contraction lasting more than 60 minutes. Correct answer is more than 5 contractions per 10 minutes for at least 20-minute period. This is worth memorizing exactly. Tachysystole is about frequency. Too many contractions. More than 5 contractions is 10-minute average over a 20-minute period. Now compare that with the next term we are going to discuss, hypertonicity. Hypertonicity is not primarily about how many contractions occur. It is about how long an individual contraction lasts. So make 2 boxes in your brain. Tachysystole means too many and hypertonicity means too long. And hyperstimulation can involve tachysystole or hypertonicity with fetal heart rate changes. That distinction is extremely testable. Okay, I gave you the clue already. Which finding represent uterine hypertonicity in the guideline definition of hyperstimulation? Contraction lasting more than 30 seconds, contraction lasting more than 60 seconds, contraction lasting more than 90 seconds, contraction lasting more than 2 minutes, and 3 contraction within 10 minutes. A contraction lasting at least 2 minutes. So now put the definitions together. Tachysystole, more than 5 contractions in 10 minutes, average over 20 minutes, and hypertonicity, an individual contraction lasting 2 minutes or more. And NICE uses the term uterine hyperstimulation when the uterine tachysystole or hypertonicity is associated with, yes, please, fetal heart rate changes. This is where candidates often mix everything together and say too many contractions mean hyperstimulation. Not quite. The terminology matters. Too many contractions, tachysystole, too long contraction, hypertonicity. Either of these with fetal heart rate changes fits hyperstimulation. So if the examiner gives you 6 contraction in 10 minutes repeatedly, think tachysystole. And if they give you 1 contraction lasting 130 seconds, think hypertonicity. And if either is accompanied by fetal heart rate changes after induction agent, now you're worried about hyperstimulation. Okay, now let's change the setting completely. Which woman is the best candidate for outpatient induction? A, severe preeclampsia. B, fetal growth restriction with fetal compromise. C, low risk woman without medical obstetric complication who wishes to return home. D, abnormal CTG. E, significant antepartum hemorrhage. This one should be quick. Correct answer is low risk woman without medical obstetric complication who wishes to return home. Let's understand the principle. Outpatient induction is not we don't have a bed, so go home. Absolutely not. It's a planned pathway for appropriately selected women. NICE says outpatient induction may be considered with vaginal Dinoprostone preparations or mechanical method in women who wishes to return home and who have no existing medical or obstetric complication. They have a normal CTG, they have a viable pregnancy, they have access to transport and support at home, and they understand and consent to the plan and when to return. So immediately eliminate preeclampsia, immediately eliminate fetal growth restriction, fetal compromise. They need monitoring, obviously. So the best candidate is an uncomplicated, appropriately selected low-risk woman who understands the pain and wishes to return home. And whenever you see outpatient care in an exam, your next thought should automatically be safety netting, which takes us directly to question number 14. A woman undergoing outpatient induction with vaginal dinoprostone phones because her membranes are ruptured. What should she be advised? A. Remain at home until contractions are regular. B. Take another dose of dinoprostone. C. Contact return to the maternity service as instructed. D. Wait 24 hours. And E. Perform a membrane sweep herself. Okay. I think you know that contact or return to the maternity service as instructed. This is why outpatient induction requires excellent counseling before the woman leaves the hospital. She needs clear instructions about when to contact the maternity unit. She should contact the cervix if the contractions start, her membranes rupture, she develops vaginal bleeding, or she has regular painful contraction, or she has any other concerns. So in this question, spontaneous rupture membrane changes the situation. She requires reassessment and an updated management plan. Do not tell her just stay home until contraction become regular. No. And definitely don't advise another prostaglandin dose over the phone. This question is really testing one phrase. Outpatient induction is only safe when outpatient safety netting is excellent. If we send someone home, she must know exactly when and how to come back. Okay, question 15 looks simple, but it tests counseling. Which statement should be included when counseling a woman before induction? A. Induced labor is always less painful. No, no. Option B, induced labor may be more painful than spontaneous labor. Option C, epidural is contraindicated. No. Only opioid analgesia can be used. No. Option E, analgesia should be avoided until active labor. The correct answer is B, induced labor may be more painful than spontaneous labor. And this should actually be discussed before induction begins. We should know that induced labor may be more painful. But here is the second half of the counseling. It matters. The usual pain relief options should still be available. Induction does not mean, sorry, you cannot have an epidural. No. Epidural analgesia is not contraindicated merely because labor was induced. Other pharmacological and non-pharmacological options can also be used according to clinical situation and maternal preference. So eliminate C, D, and E. The woman does not have to wait until some arbitrary point in active labor because she is allowed analgesia. This is a part of good informed consent. We should not only tell a woman we need to induce you, we should explain why, how, and how long it might take, and what examination and monitoring may be needed, and what the possible complications are, and what the experience may feel like. Good induction care starts with good counseling. Good. Okay. Now, this is one of my favorite questions because it exposes a very common exam reflex. A clinically stable woman has an unsuccessful induction. Maternal reassessment and CTG are reassuring. What is the most appropriate principle of management? Option A, immediate cesarean birth is mandatory. Option B, discharge without further discussion. Option C, discuss and individualize further management with the woman. Option D, start oxytocin regardless of cervical finding. Option E, repeat prostaglandins indefinitely. C. The correct answer is discuss and individualize further management of the woman. NICE uses the term unsuccessful induction when labor does not start after one cycle of treatment. And what happened next? First, reassess the woman and the pregnancy, then discuss further management. Depending on the clinical situation, the woman's preference options may include a rest period. It may include expected management. It may include another induction attempt. It may include a cesarean birth. So there is no universal equation that unsuccessful induction means immediate C-section. That is a trap. You have to look at the indication for induction, the gestation rate, the maternal condition, the fetal condition, the cervical finding, what already has been tried, and the woman's informed choice. Now, of course, if the maternal fetal compromise occurs, the urgency and options change. But this term deliberately tells you matter is stable, CTG reassuring, that is exam saying don't panic, think. And the best answer is yes, please. Share decision making and individualized management. Okay, now remember question number 7. I told you not to perform amniotomy blindly when the head is high. So question 17 tells you exactly why. Before amniotomy during induction, the fetal head is found to be high and stable. What is the major concern? A. Shoulder dystocia. B. cord prolapse. C. Placental abruption. D. Uterine inversion. And E. Cervical tear. What is the major concern? Good. Cord prolapse. Think mechanically. Normally, when the presenting part is well applied to the cervix, it occupies the space above the cervix. But if the head is high and mobile, there's room between the presenting part and the cervix. So if you rupture the membrane, the liquor suddenly drains, the umbilical cord may descend past the presenting part. That is cord prolapse. And cord prolapse is an obstetric emergency because cord compression can rapidly compromise fetal oxygenation. So before amniotomy, assess the level and stability of the presenting part. If the head is not stable and well applied, be extremely cautious. This gives you a beautiful exam connection. Question 7 was asked, what do I assess before induction? And question 17 asked, why does the assessment matter? Because a high unstable presenting part plus ARM can equal cord prolapse. Clinical reasoning, not isolated memorization. So question number 18 changes the clinical context completely. So reset your brain before answering. A woman with intrauterine fetal death and a non-scarred uterus chooses induction. Which is an appropriate pharmacological approach according to the guideline material? A. Oxytocin alone. B. Oral mifepristone 200 milligram followed by dinoprostone misoprostol. C. Methotrexate followed by oxytocin. D. Mifepristone 600 mg alone and dinoprostone is absolutely contraindicated. Okay, now we are dealing with intrauterine fetal death, and the woman has a non-scarred uterus and chooses induction. Which pharmacological approach is appropriate? Correct answer is B. Oral mifepristone 200 milligram followed by dinoprostone or misoprostol. And this is exactly why you should never learn. Mifepristone is not used for induction. Context matters. Earlier, when we discussed routine induction for life-term pregnancy, mifepristone was not a standard cervical ripening agent. But in the setting of IUFD, the pathway is different. For a woman with IUFD who chooses medical induction and has no previous cesarean, NICE recommends mifepristone 200 mg followed orally, followed by dinoprostone or misoprostol. So this is an excellent exam lesson. Same drug, different clinical situation, different answer. Do not answer a question from the drug name alone. Read the entire question. And there's another major distinction coming. What if the woman with IUFD has a previous cesarean scar? That requires extra caution because the evidence and the safety consideration around the prostaglandin regimen in a scarred uterus are different. So whenever you see intrauterine fetal death in an induction question, immediately identify it as scarred or non-scarred uterus. That single detail can change your management. Okay. Stop here for 10 seconds. Before you continue, I want you to see how much information we just connected. After prostaglandin induction, contraction start, assess the fetal well-being and uterine activity. If everything is okay and there's no other indication for continuous CTG, intermittent auscultation may be appropriate. If uterine activity become excessive with fetal artery abnormality, think hyperstimulation. Tachysystole means too many. Hypertonicity means too long contraction. And hyperstimulation is abnormal fetal heart rate with abnormal uterine activity. Management क्या है उसकी? Stop further induction medication, assess, remove or remove vaginal preparation if possible, consider dialysis. For outpatient induction, choose women carefully and give clear safety advice. For unsuccessful induction, do not automatically jump to C-section. Reassess, discuss, individualize. Before ARM, high unstable head, think of cord prolapse. And for intrauterine fetal death, always scarred. It is scarred or a non-scarred. So now everyone, question 19, we're almost here. A woman has fetal growth restriction with confirmed fetal compromise. Birth is required. What does the guideline recommend? A. Membrane sweep. B. Dinoprostone induction. C. Misoprostol induction. D. Cesarean birth rather than induction. E. Outpatient induction. Pause the video. And before choosing the answer, tell me, what is the most important phrase in this question? Exactly. Confirm fetal compromise. And therefore, the correct answer is cesarean birth rather than induction. Now, this is an important distinction. Please do not leave this question thinking fetal growth restriction means C-section. No. The guideline says, is there a fetal compromise or not? If there's fetal growth restriction without confirmed fetal compromise, induction of labor can be offered when birth is indicated. But if there is confirmed fetal compromise, NICE recommends not inducing labor and offering cesarean birth instead. Why? Think about the physiology. A growth-restricted fetus may already have limited placental reserve. Labor is essentially a repeated physiological stress test. With every uterine contraction, uteroplacental blood flow temporarily falls. So a healthy fetus with good reserve usually tolerates that. But a compromised fetal growth restricted fetus may have very little reserve felt. So asking that fetus to tolerate hours of cervical ripening, then contractions and labor may expose it to further hypoxic stress. That is why when fetal compromise is already confirmed and delivery is required, the safer route is generally C-section rather than induction. Now look at the distractors. Mammalian sweep. No, we are not trying to gently encourage spontaneous labor in a compromised fetus requiring delivery. Dinoprostone or misoprostol. Again, no, because that begins an induction process that is compromised fetus may not safely tolerate. Outpatient induction, definitely not. A pregnancy complicated by confirmed fetal compromise is not an outpatient induction scenario. So the important exam point that fetal growth restriction is not automatic C-section. Fetal growth restriction plus confirmed fetal compromise do not induce or offer C-section. And notice how the examiner can completely change your answer with just two words, fetal compromise. So always hunt for these decisive words in a question. Okay. Now, here we are. Question number 20. A non-diabetic woman has suspected fetal macrosomia. She asks whether induction will definitely prevent complication. Which counsel statement is more appropriate? A. Induction of labor eliminates shoulder dystocia. B. Cesarean birth is mandatory. C. Expected management is mandatory. D. There's uncertainty about the overall benefits and risk of induction of labor versus expected management. And E. Induction of labor definitely reduces emergency C-section. C. A non-diabetic woman has suspected fetal macrosomia. She asked, Doctor, if I have an induction, will that definitely prevent complication? Which counseling statement is most appropriate? Before you answer, notice another tiny but extremely important phrase, without diabetes. Pause the video and choose the answer. The correct answer is D. There is uncertainty about the overall benefits and risk of induction of labor versus expected management. This is a fantastic counseling question because there is no absolute answer. And whenever an option says always, definitely, mandatory, eliminate, your exam antenna should go up. Medicine is really that absolute. For a woman with suspected fetal macrosomia without diabetes, NICE recommend discussing the options of expectant management, induction of labor, C-section, and the woman should be counseled that there's uncertainty about the overall benefits and risk of induction compared with expected management. But we do have some evidence to discuss. Compared with expected management, induction associated with a lower risk of shoulder dystocia, so that induction eliminates shoulder dystocia. No, it reduces the risk. It does not make it zero. On the other hand, induction is associated with an increased risk of third and fourth degree perineal tear. So according to NICE evidence discussion, there was no demonstrated difference in some other outcomes, including perineal death, brachial plexus injury, or emergency C-section. So look how balanced the counseling needs to be. I cannot tell this woman induction is definitely better. I can also not say induction method is definitely better. Certainly cannot say you have a big baby, therefore C-section is mandatory. Instead, I explain the available situation, the uncertainties, the potential benefits and harms, and then make a decision with the woman based on individual circumstances and preference. And one more exam prep. This question specifically says without diabetes. If diabetes is present, do not blindly apply this exact counseling pathway because diabetes changes the risk profile and management recommendation. So your final pearl from question 20 is suspected macrosomia without diabetes, no one size fits all answer. Counsel, discuss options and use shared decision makers. And finally, we did it. 20 high yield questions on induction of labor completed. And now tell me yours. So was it 20 of 20 or 18 out of 20 or 15 out of 20, or did the bishop score and hyperstimulation attack you somewhere in the middle? Whatever your score was, don't just count your correct answer. Go back to the questions you got wrong and ask, why did I choose the wrong option? Because that is where your real learning happened. And before we finish, let me give you the entire induction path in less than 1 minute. Start with the indication. Does the woman actually need induction? Then reassess the mother and fetus, confirm the fetal presentation, fetal well-being, and the level and stability of the presenting part. Then assess the fetus. Bishop score 6 or less or more than 6. Then cervical ripening, pharmacological methods such as vaginal dinoprostone or low dose misoprostol, or consider mechanical method depending on the clinical situation. Bishop more than 6 in amniotomy plus into. Once induction start, monitor know the difference between tachysystole or hypertonicity and abnormal uterine activities associated with fetal heart rate changes, then think hyperstimulation and act. Stop further induction medication, assist the fetus, removal vaginal preparation possible, consider to cholesterol. If induction is unsuccessful, reassess the mother. Don't reflexively jump to C-section. And it's a special situation, previous C-section, intrauterine fetal, that fetal growth restrictions, suspected macrosomia. Don't memorize one universal induction formula. The clinical context changes as resident. And that is really the message I want you to take from today's lecture. Don't memorize the answer, understand the decision. Because once you understand why you are choosing something, even if the examiner changes the wording of the question, you can still reach the correct answer. If this lecture helped you revise these 20 questions again after a few days without looking at the answer, and that is how you convert information to a exam recall. Keep practicing, keep learning, keep shining, and we don't stop here. Wait a bit. We successfully induced our patient. She is contracting. The cervix is dilating. The fetal heart is being monitored. So our job is done, right? Not even close. Because now she enters the labor room and a completely new set of questions begins. When exactly is labor established? How often should we examine her? What is actually considered normal progress and when should slow progress worry us? When should we simply wait? When should we perform amniotomy? When should we start oxytocin? And most importantly, how do you differentiate normal labor from labor dystocia without intervening too early or too late? And that is exactly what we're going to discuss in our next labor module lecture, intrapartum care, normal labor and labor dystocia based on the updated NICE guideline. So now that we know how to get a patient into labor, next we are going to learn how to manage her once she gets there. I'll see you in the labor room next lecture in OBG with OBG with Sadia Idrees. Like, share, and subscribe. Allah Hafiz.